Positioning Lesson 1 is chest radiography, the most commonly performed radiographic examination in medicine. You will take thousands of chest x-rays in your career. The standard is a PA and lateral. Every positioning decision you make, where you center, how you instruct the patient to breathe, which AC chambers you select, directly affects whether the image is diagnostic. 14 minutes. Let's build this from the beginning. The PA chest is the standard view. PA means the beam enters from the posterior, the patient's back, and exits anteriorly through the chest wall toward the image receptor. Patient position. The patient stands upright, facing the IR, the image receptor. The chin is elevated, resting on or above the top edge of the IR. The arms are abducted, elevated and rotated so the shoulders roll forward. This forward rotation of the shoulders is the key positioning move. It rotates the scapulae laterally and clears them from the lung fields. Female patients. Breasts are lifted and separated from the lower lung zones to prevent them from obscuring the bases. Technical setup. Ishi 72 inches, 183 centímetros. This is the chest standard. The long distance minimizes cardiac magnification and reduces patient skin entrance dose compared to a shorter SID, KVP, 110 to 125. High KVP produces a long scale of contrast, many gray levels, which allows simultaneous visualization of the lung parenchyma and the denser mediastinal structures. ISC, Lateral chambers selected. Grid, yes, 8 to 1 or higher. Central ray, horizontal, perpendicular to the IR, centered to T7, which is at the level of the inferior angle of the scapulae. Midline of the patient to the midline of the IR. Collimate just beyond the lateral chest walls. All four sides visible on the image. The left lateral is the standard for routine chest work. Left lateral means the patient's left side is placed against the IR. The reason: the heart is positioned on the left side of the chest. Placing it closer to the IR reduces cardiac magnification compared to a right lateral. The right lateral is ordered specifically when right-sided pathology is suspected and a right side-down view is needed. Patient position. Arms raised overhead, grasped together above the head. The body must be in true lateral, no rotation. The mid-sagittal plane must be parallel to the IR. Central ray. Horizontal, perpendicular to the IR, at the level of T7. Ishi 72 inches. KVP 125. AC. Center chamber is appropriate for the lateral view. 7 evaluation criteria for the lateral. Lung fields from the apices to the costophrenic angles. Retrosternal clear space visible anteriorly. The dark air space between the sternum and the heart. Posterior ribs superimposed. True lateral, no rotation. The vertebral column should appear progressively darker, moving inferiorly. Diaphragm domes visible. Right dome normally higher than left. The heart shadow lies anterior and inferior. And no rotation. Sternal edges superimposed. 6 criteria, and the registry tests every one of them directly. Inspiration. 10 posterior ribs must be visible above the right hemidiaphragm on a full inspiration. Count posterior rib heads from the top. Rib 1 to rib 10 above the diaphragm. 8 ribs visible means the patient took an inadequate breath. 9 or 10 is diagnostic. Rotation. The spinous process must be centered midway between the medial ends of both clavicles. If one sternoclavicular joint appears wider than the other, the patient is rotated. Exposure adequacy. Thoracic vertebral bodies should be visible through the cardiac shadow. If the spine is not visible through the heart, the image is underexposed. Too dark, overexposed. Scapulae position. Both scapulae must be rotated out of the lung fields. If scapular shadows overlay the lungs, the shoulders were not properly rolled forward. Anatomy included. All 4 costophrenic angles visible. Both lung apices 1 inch above the clavicles. Both diaphragms. The entire cardiac silhouette. And the cardiothoracic ratio. On the PA view, the width of the cardiac shadow should not exceed 50% of the total thoracic width. Greater than 50% indicates cardiomegaly, an enlarged heart. For special chest projections with clinical purposes. AP axial, the lordotic position. The patient leans backward into a lordotic arch, or the tube is angled 15 to 20 degrees cephalically. This lifts the clavicles above the lung apices, revealing the apical lung tissue free from bony overlap. Used for detecting tuberculosis, TB, at the lung apex, Pancoast tumor, and right middle lobe evaluation. Lateral Decubitus. The patient lies on their side with a horizontal beam. Left lateral Decubitus. Patient on the left side demonstrates free air rising to the non-dependent right side and shows fluid layering on the dependent left side. Right lateral Decubitus does the opposite for right-sided pathology. The patient must lie in position for at least 5 minutes before exposure to allow fluid or air to redistribute. Both costophrenic angles must be included on the IR. AP portable. SID, 40 to 48 inches. Document the actual SID used. KVP, 80 to 90. Lower than PA because supine technique requires less penetration. The heart appears larger on AP compared to PA because the heart is further from the IR. More cardiac magnification. The diaphragm rides higher in the supine position. The lung bases appear denser. Expiration PA. Same position as the standard PA, taken in full expiration. Purpose: detect a small pneumothorax. The contracted lung makes the pleural air more visible. Also demonstrates air trapping. One lung that stays large on expiration while the other deflates. The bar chart on this slide shows relative MES adjustments for common chest pathologies compared to standard technique. 2 directions: increase or decrease. Emphysema. Decrease MES by 25 to 35%. Emphysema destroys alveolar tissue and replaces it with air. Air attenuates the beam far less than normal lung tissue. Standard technique produces an overexposed, too dark image. This is a destructive pathology. Pleural effusion. Increase MES by 30 to 40%. Fluid in the pleural space adds significant density to the affected side. More radiation needed to penetrate it. Pneumonia and consolidation. Increase MES by 20 to 30%. Alveolar consolidation replaces air with fluid and cellular debris. Increased density. KVP. Fixed at 110 to 125 for the PA. High KVP is the standard for chest. It produces the long-scale contrast needed to see both lung and mediastinum on the same image. AEC chamber selection. Always use the 2 lateral chambers for chest radiography. The center chamber lies over the mediastinum, a dense structure. If the center chamber drives the exposure, the system terminates early trying to penetrate the heart and great vessels, and the lung fields will be underexposed. Use lateral chambers. Always. Portable chest. Reduce MES by approximately 70% compared to the PA technique at 72 inches. This accounts for the shorter SID, approximately 40 to 48 inches, and the supine position. 3 chest radiography questions. Think each one through before the answer appears. The answer is B. The patient did not take a full inspiration. 10 posterior ribs above the right hemidiaphragm is the standard for a full inspiration chest radiograph. Only 8 visible ribs means the diaphragm did not descend fully. The patient took an inadequate breath. The lung bases appear denser. The cardiac silhouette appears larger, and mediastinum appears wider than it truly is. Instruct the patient to take a full, deep breath and hold it before pressing the exposure button. The answer is B, both lateral chambers over the lung fields. For chest radiography, the 2 lateral AEC chambers must always be selected. The center chamber lies directly over the mediastinum. If the center chamber drives the exposure, the AEC will try to penetrate the dense heart and great vessels. It will keep running longer than needed, overexposing the mediastinum while the lung fields still receive inadequate exposure. The lateral chambers sample lung tissue, the actual target of the chest examination. The answer is B, right lateral decubitus, with the patient lying on the right side. Free pleural effusion layers to the dependent side under gravity. For a right pleural effusion, the patient lies on the right side. The right chest becomes the lowest point, and free fluid layers along the right lateral chest wall. This confirms the fluid is free-flowing and not loculated, and uncovers the underlying lung parenchyma. The patient must remain in the decubitus position for at least 5 minutes before the exposure is made. Lesson 1 complete. You covered PA chest positioning, the long SID, lateral chamber selection, and shoulder roll. The left lateral, retrosternal clear space, and posterior rib superimposition. The 6 evaluation criteria, the 10-rib rule, cardiothoracic ratio, and rotation check. Special projections including Lordotic, Decubitus, portable, and expiration. And pathology technique adjustments for emphysema, effusion, and pneumonia. The chest radiograph is your most frequent exam. These standards apply every day.